Welcome, everyone. My name is Jen Sharon, NHIA's Chief Operating Officer and your moderator for today's fourth session in our COVID series, Expanding Oncology in the Home Setting. I'd like to take a moment to thank our generous sponsor of the COVID series, McKesson, and NHIA Future of Infusion Advisory Council and NHIA Gold member. We have Bobby Nichols from McKesson here to say a few words. Bobby?
Good afternoon and thank you. My name is Bobby Nicholson. I'm the Area Sales Manager for the East Region for McKesson's Home Infusion Division. I'm excited to be here today to sponsor the NHIA webinar focused on expanding oncology in the home setting, especially with how the home healthcare industry has evolved with COVID-19. McKesson is the leading distributor of infusion therapy supplies, devices, and pharmaceuticals, as well as technology solutions around asset management and patient engagement. We understand that the needs of our customers and our own needs are changing in this new environment and the support needed in connecting with patients remotely. We appreciate the sponsorship with NHIA and all of you. We're excited to sponsor, but I'm also excited to hear today's speakers. And Jennifer, I'll turn it back over to you.
Thanks so much. We truly appreciate McKesson's support of the home infusion industry and the entire COVID-19 series. Our final program for the COVID-19 series will be a vaccine update with Dr. Kane. Make sure to watch Infusion Express for registration links or visit NHIA's website, click on Learn, CE Education, COVID series to register for future events or catch up on education you missed. Just a couple of housekeeping reminders. The presentation is available for download from the handout section of the navigation pane, as well as the speaker bios. The webinar will be recorded. A link to the recording will be emailed to you following the conclusion of the webinar and will also be available via NHIA's website within the next 24 hours. In order to receive CE, please follow the link in the follow-up email and answer a short quiz. Following the presentation, we will have time to answer your questions. Please submit your questions via the question tab in the navigation pane at any time during the presentation. All right, now on to our presentation. Joining us today to share their knowledge is the awesome team from UPenn, Cass Redmond, Suzanne McGettigan, Catherine Major, and Justin Beckelman. We are very excited for you all to share your knowledge and passion for expanding oncology in the home. I know you have a lot of great information to cover, so let's get started, Justin.
Terrific. Nice to be talking with everybody. And I just want to give a shout out to this, you're right, this awesome team from Penn Medicine, Catherine Major, Suzanne McGettigan, and Cass Redmond. I just happen to be going first and be representing the team first. But this has been an incredible team effort, and we're just so delighted to be able to talk to you all about it. The objectives today, as you can see, review the need for options for anti-cancer therapy administration during the pandemic, discuss the therapies and regimens being administered in the home setting, describe the clinical management and safety for the patient and healthcare provider, and discuss barriers to implementation of a home anti-cancer therapy program. We've got an awesome program for you, so we're excited to dig right in. So we'll go to the next slide, Cass. So we'll just start right at the top here. Penn Medicine's Cancer Care at Home program, we have demonstrated that home infusion of anti-cancer therapies could, for appropriate cancer drugs in patient populations, take the place, literally substitute for inpatient or outpatient administration. And, you know, to make this easy, Cass, you can just put it on, yeah, and it'll just go through. That's perfect. And we can just advance the slides. That's great. So we've improved patient experience, we've improved clinician experience, and we've also improved Penn Medicine's capacity to provide world-class cancer care. And we start here because I think a lot of folks have heard about the program because it's been covered in the national media. But it comes down to why was it covered in the national media? I think it was covered in the national media because in the end, it was demonstrated to have achieved such wonderful patient-centered care. Go ahead, Cass. Let's go to the next one. How did we get there? Well, we had the right team. Here at Penn Medicine, we're an integrated health system. There are 6 hospitals. The footprint of oncology practices spans 12 locations around Southeast Pennsylvania and New Jersey. There are upwards of 100 or more infusion chairs. Obviously, we have a very active inpatient program for our patients with cancer. When we thought about moving cancer home, we started doing this before the pandemic in November of 2019, and we established a program that included leaders from Penn Home Infusion Therapy, the Division of Hem/Onc, the Cancer Service Line, Infusion Services, our Strategic Decision Support and Managed Care, as well as the hospital leadership and our innovation leadership. I run a program here at Penn in the Cancer Center, which is the Cancer Center's innovation program. I'm also an oncologist and practicing clinician. And number one, we focused on safety and quality. We focused on shared decision-making between patients and their physicians about the site of care. We focused on maintaining the crucial linkage with the treating oncologist. We focused on delivering care through our incredible oncology certified nursing team that Catherine is going to be talking to you about. And we made sure that in any case that we were delivering cancer treatment at home, the benefits outweighed the risks. We had this viewpoint from day one in November. And yes, as the pandemic hit, we can go to the next slide, Cass. As the pandemic hit, of course, there was a tremendous urgency to scale this program, but we were able to scale so quickly because we were prepared. We were prepared not only because of the team we started developing in November of 2019, but also because Penn Home Infusion Therapy has been delivering home-infused medicines to patients, some of whom have cancer, now for decades. This was new because the agents we were experimenting with, Lupron, EPOC, pembrolizumab, you name it, these in some cases hadn't been delivered at home in our area or in the US, but nonetheless, we had the experience already, and that allowed us to scale the program as we have. In fact, today, Lupron and EPOC, it's standard of care at Penn Medicine to provide these medicines at home. We can go to the next slide. I'll end here with this introduction by just referring to Miss Harmon, Desiree Harmon, who's one of our patients here at Penn Medicine, and she was one of the first patients to be part of the program. She has breast cancer, and for the past 5 years has been coming literally monthly for a subcutaneous Lupron injection. And she gave us these quotes. "I called it my calendar killer. I had to work my life around this shot. Now, as much as I love Penn, not having to go there gives me peace of mind." And these are the types of stories, and there's others we can share, where patients were just delighted at how effective the program was. And frankly, as a result of their delight, our clinicians were equally delighted, and it's why we were able to scale so quickly and ultimately make this standard of care. So with that introduction, I'm going to turn it over to Cass.
Thank you, Justin. I appreciate the introduction and going on, and slides don't want to shuffle. There we go. So I think that the biggest question most people probably have relates to how we were able to do this. So I'm just going to take a couple minutes, give you a background on Penn Home Infusion Therapy before turning it over to Catherine and Suzanne to really dig into the project. So Penn Home Infusion Therapy, or PHIT, as we like to call it, started as a home infusion provider for about 30 patients in our local area, so just right around the King of Prussia area. And we serviced just TPNs initially. Over the past 25 years, we've actually morphed into a pretty impressive operation. We're servicing about 2,500 patients across 3 states now. That's kind of the Pennsylvania, New Jersey, and the northern part of Delaware area. Our clean room is cranking out about 900 products per day. Drivers are on the road delivering close to 200 deliveries a day, and our nurses are in the field reaching and touching about 200 patients per day. So like many of you, we have 24-hour a day, 7-day a week nursing and pharmacist coverage, and our patients are assigned to pretty specific disease state teams that are our clinical teams. But what we feel actually sets us apart is our holistic clinical model and being part of an integrated team across Penn Medicine and home. So Penn Home Infusion has access to home health, palliative care, and even hospice resources for our patients. And of course, as Justin said, kind of being part of that Penn health system, we get to partner with our different service lines that best meet the needs of our patients in the safest and most effective clinical manner. So our program promotes best in practice and expert care with a focus on patient safety and satisfaction. And some of the keys to our infrastructure that really helped support this cancer care at home project and allowed us to adapt so rapidly include the ability to provide PRN therapies even on same days if really needed. We do some first dose medications in the home if it's an approved medication or therapy. We can do lab draws. We even get our labs resulted in the same day for some of our clinical providers that really help drive decisions. And our experience with a large range of therapies that are included at the bottom of this slide really showed where our depth was. One of the key drivers for us is the involvement of our business development liaisons that actually acted as patient navigators throughout the entire process. And this slide, while a little busy, is our process. So as you can see, there are a lot of touch points from everything from our intake and insurance authorization to the care teams, the schedulers, preparation of medications, deliveries, and the nurses in the home. Patients could easily get lost in this process or have questions along the way. So having our business development liaison helping to navigate the patient along with the provider really has been a true value. And I do want to point out that regardless of who in this process is touching the patient, they all have that patient need at the forefront. And that's the infrastructure that allows us to continue program growth and development. So I mentioned our disease-specific care teams. So I want to take a minute to talk specifically about the hematology oncology care team. So you can see this is a pretty large team that has 13 staff members, 4 pharmacists, 4 registered nurse coordinators, 3 patient supply representatives, and 2 patient service associates. The patient supply reps call the patients every week, talk through their supply needs, and set up deliveries. Patient service associates really help coordinate the visits and the scheduling along with the nurse coordinators. So this team is responsible for about 1/3 of our patients. That's both pre-COVID and during COVID. And prior to the Cancer Care at Home project, this team had experience in handling a variety of therapies, some of which are shown here at the bottom of the slide, including 5-FU, IVIG, hormone replacements. So shifting from the office-based staff to kind of those direct care nurses, the direct care nurses are really a jack of all trades. They're trained and get competency in administering all the therapies offered by Penn Home Infusion. The requirements of our direct care staff include a minimum of 3 years experience in a critical care area. And we get all of our nurses to do ONS certification, so they complete the courses and they're all certified. And that helps us ensure safe administration of these anti-cancer therapies in the home. During the pandemic, we flexed our muscles internally and really across the health system to help meet the needs of all the patients, getting them service in the area that was safest for them. We were able to really utilize cross-training for internal staff within Penn Home Infusion, as well as across the health system. So again, we had our business development folks helping out with some referrals and insurance authorizations. Catherine worked to help get some additional ONS courses provided, so home health nurses could be trained to help with the chemo takedowns. And then on the health system level, we had resources from inpatient and clinical settings that had been displaced due to the low census that were able to help support the increased volumes. We utilized them in both our compounding areas as well as to help with nursing visits. So just to back up a little bit, I'd like to talk about our medication review process. So we said we do a lot of therapies as long as they're approved in the home. So when Catherine will talk later about kind of how we pick the right drugs, you'll understand this background process a little bit more. As part of a large health system, we have an ambulatory P&T committee, and they provide formulary review of all the products for the health system. However, kind of as the licensed retail pharmacy that deals with a bunch of alternate payer contracts, we really use that information as guidance to see how the health system feels about the medication, and then we conduct our own review of the therapy, really with a focus of, is this safe and does it make sense that we can administer at home? We look at things like ease of administration, complexity of preparation. Is it a NIOSH listed agent? And what does that mean that we have to have? What is the overall stability? If we deem the therapy is appropriate for the home, we'll go ahead and approve it for use, and we'll create a staff education plan. Part of that education plan is this document, which we put on here for Lupron. And Basically what this does is it outlines all of the common features of the medication. So the indication for use, the mechanism of action, the dosing, the things we would expect. But then it also has other areas like specific preparation details. So it helps guide the pharmacy technicians when they're preparing it. This document also includes any particular special tubing needs or filtration needs. And it has nursing specific notes, including monitoring parameters. So this goes out to all staff via many routes. It's emailed, it's presented in staff meetings and discipline meetings. We really like to make sure that everyone has it. And then it's put into a like a shared drive for everyone. All of our staff members can go back and grab it at any point in time that they would need it. In addition to medication review and staff education documents, we have a number of additional safety protocols in place, and they're highlighted here. So we have a specific set of drugs that we allow first dose administration in the home. We have a list of medications that require our nurse to sit through the entire administration and then usually an hour afterwards. We have infusion-related reaction protocols. What are the steps the nurse has to take should someone have a infusion-related reaction? And we have a chemo double check process. So now that you have a good understanding of Penn home infusion therapy, I'm going to introduce my colleague, Catherine Major, and she's going to discuss the initiation of the Cancer Care at Home project.
Thank you, Cass, for providing everyone with some background about Penn home infusion therapy. And so what I'm going to talk about is how we started to initiate this Cancer Care at Home project and what steps we took throughout the health system to get us all on the same page and to start moving some of these initiatives forward for our patient population. So in September and October, ballpark about a year ago, we had a meeting with the other executive sponsors from the health system. We decided that we wanted to take cancer care to the next level. And so what we did in that meeting was where we identified the stakeholders, who's important to make these decisions, who do we need to get input from and have them sitting at the table. And then based off of those two things, the executive sponsors and the identified stakeholders, we created the right team with the right expertise to start to put our first steps in place to move this program forward. Next, Cass. So when I talk about the right team, we wanted coordination. And as Dr. Beckelman had talked about before with this slide, is that we work in a super complex arena. There are a ton of players here, as you can tell from this slide here. And our health system has a vast range of complexity that services our patient population. So all of us were starting to really focus on Penn home infusion therapy, that piece at the 2 o'clock spot right there, and how we could all work together to really bring these home infusion medications to our patients in a more comprehensive and safe manner in their home. Next slide. So then that was our first step. Our next step in November and December was, let's figure out exactly what types of medications are going to be appropriate for our patients. How do we ensure that they're safe and that the nurses are prepared to administer these medications? Are the physicians prepared to have this medication administered in an alternate setting? And are patients and families open to this idea? And so when we were thinking about these patients, which are always in the forefront of our thought processes and our decision making, we think about them being in situations that might not be super comfortable. And as much as we try to have infusion suites to be comfortable and to be places that are warm and welcoming, there really is no place like home. There's family support. There's, just your own comfy chair and your cozy slippers that you have in the home. That we really wanted to pull that aspect of healing and that aspect of your own personal comfort into your treatment. And so in November and December in 2019, we started to talk about which types of patients are we going to be able to implement this therapy for. So we decided on Lupron and EPOC. And so we selected these to demonstrate the feasibility at 2 operational extremes. So if you think of Lupron, that it's pretty straightforward about being, just a very simple injection that takes, just a few minutes from when the patient arrives and meets with the nurse and after verification to administer. So what we found was that when patients were going to the suites, they would set up a 15-minute time frame for those patients to be in that room, even though the injection only took a way shorter amount of time. So just this concept of having these patients receiving these injections at home, it freed up 40 chair minutes. And so then we also decided to do EPOC. And EPOC is the other end of the spectrum of being a very complex multi-drug intravenous infusion. And typically it's delivered in an inpatient setting for aggressive non-Hodgkin's lymphoma. And it includes a 96 hours continuous infusion, a combination chemotherapy. And patients then receive 6 5-day cycles every 21 days. So we went from a simple injection to a fairly complex regimen here. And so every cycle, once we implemented EPOC, freed up 5 bed days from the hospital setting. So then as we started to move into January and February, we created streamlined workflows and processes which would optimize our PHIT infrastructure. And what that means is we started to pull on our resources throughout the health system in order to implement this. And Cass had touched on this with our professional development division for nursing and getting all of our nurses to the point where they were chemo certified and comfortable administering these medications. And we began providing these medications in the home. That's when we officially kicked it off. So all of that planning from September through December started to come to fruition in the beginning of 2020. And it was pretty exciting. So now I'm going to transition the next portion of this to my colleague, Suzanne McGettigan. Suzanne.
Thanks, Catherine. So a lot of the work that had been done as part of the Cancer Care at Home project really then come March had to transition into being more standard of care as we were trying to expand the number of patients who would be eligible for some of these therapies. We really had to get away from like a specific project where there was extra support to enable some of these patients to get enrolled on these therapies at home, to really taking advantage of some of our standard processes that were already in place. Next slide. So, and at the same time, COVID-19 came. So in the midst of a pandemic, there was a big push from providers, from patients, from all the healthcare staff to really try and identify which patients really we should try to not have them come into the office, which staff potentially shouldn't be coming into the office, and how we could change the way we were delivering care in the midst of the pandemic. So some of the things that were happening at this time from a health system standpoint, a lot of our staff were really transitioning from having purely 100% clinical in the office, seeing patients every day, to doing a mix of kind of in-person visits and telemedicine visits, and kind of depending on the disease team, there was different proportions of how much time was really spent in person in the clinic versus how much time was really able to be spent at home doing telemedicine or doing other, kind of clinical non-patient facing work. We also, during that time, implemented social distancing in our offices. So a lot of our support staff, so our nurses, our triage nurses that really help with symptom management and are an integral part of our HEMONC team, also were at this time really transitioning to working primarily from home. So we did need to figure out different ways of kind of getting, kind of even just some simple things like getting orders from our EMR to Penn Home Infusion or Penn Care at Home to enable patients to enroll on this program. We also in the clinic implemented universal masking for both staff and patients, and universal thermal screening, again, for both staff and for patients. Some of the clinical areas, so again, as Justin mentioned earlier, we have a number of different clinical areas in which the cancer center has space and where as we are seeing cancer patients. So some of those clinic spaces have variable amount of rooms for patients to actually practice social distancing. So there were new limits kind of placed on how many patients could potentially be seen in a given day, how many providers were able to see patients in a given day. And that occurred both on the clinic side of things as well as on the infusion side of things. Some locations reduced hours and some actually expanded their hours just so they could space patients out more throughout the day. And there was a big increase in our referrals for routine things. So some of those things that were mentioned earlier, so home hydration, home supportive care therapies at this time, again, to try and prevent patients who didn't need to come into the office or into the infusion center from doing so. And then Penn Home Infusion also implemented a number of different things during this time. So some of the activated resources that were available, a lot of areas really had cut down dramatically on their patient visits. And so there were nurses available to kind of be redeployed to Penn Home Infusion. Some of those nurses came from our infusion centers. So within the cancer center, some came from the hospital or some came from other areas. They also implemented a PPE van. So this was a van that contained all the PPE a nurse would need if she was going into a home where there was a patient who was known to have COVID-19 or was considered a PUI. And so this van traveled around to different patient homes to meet the nurse there and be able to supply the PPE that was needed to enter those homes. So in addition to doing kind of the routine home infusion therapies, there were a number of other activities that Penn Home Infusion and Penn Care at Home took on during this time. From an operational standpoint, they also really tried to focus on the most vulnerable patients. Again, those patients that we thought were high risk, which again is a lot of our cancer patients because they are immunocompromised. So really focusing their resources on identifying the most vulnerable patients, and we're able to adapt their policies and procedures to this pandemic and the different needs that patients really were experiencing during this time. So as I mentioned, so March to April, there was an acceleration of this transition of therapies into the home. And some of them really became standard of care. So Lupron and EPOC really became standard of care that we were giving these at home. And so we really needed to, I will say from a provider, I'm a nurse, I'm not sure if we said this, but as a nurse practitioner, a lot of times our advanced practice providers are the people who are putting in orders and really coordinating a patient's care at home. So it was really important that we had a standard process in place so that everyone could see that. And so that really was what had to happen during this transition to standard of care. And then from May to June, we started some additional pilots, including pembrolizumab, rituximab, and bortezomib. And you've seen this slide earlier, but you can see that really, so starting in March, the number of patients referred for Lupron skyrocketed. That's really probably the biggest population. EPOC really would, a much smaller number of patients would be candidates for that, but that was pretty steady throughout the past 7 months. And then pembrolizumab, bortezomib, and rituximab, you can see that uptake kind of starting in May to June. And then some of the challenges that we kind of had and some of the ways we tried to work through those were really, number one was really to try and increase transparency. So we were working, some of the biggest challenges were the fact that our outpatient, our ambulatory practices actually, as well as our inpatient practices really work with Epic as our EMR. But Penn Home Infusion worked with CPR, and so those two systems really can't talk. So again, during the pilot, there were a number of things that were kind of additional resources that were in place that could help with some of this coordination and with the communication between the different groups. There was a very detailed way of completing patient tracking, so the use of a business development liaison. There was a tracking tool that was sent out weekly, and we had weekly status calls to assess kind of where there were challenges, where things were going smoothly, and different things that needed to be worked on. We also worked within our EMR to develop more clear order sets. We developed dot phrases so that the provider who was ordering the Lupron to be given at home and making that referral to Penn Home Infusion alerted the patient to certain things, so that the patient was pretty clear on what the process was going to be, what calls they should expect to get from Penn Home Infusion or Penn Care at Home, giving them a little bit more idea about, kind of costs, like once they transition to receiving this therapy at home, they wouldn't be coming into the infusion center, and just really making sure that all of the information that patients would need was really clear at that time. Also, during this time, Penn Care at Home was the first group of the home care that was actually integrated into Epic. So once that happened, it was much easier for us to see the patient's home visit schedules. We could see the administration of agents in the nursing notes that were visible to us. And I will say, over the past 6 months since this integration happened, there's much more messaging that is going back and forth between the providers and the home care nurses. So, alerting us to a visit or alerting us to a finding that occurred during a visit. So that has really made things much easier. And this is just a portion of the pathway that we developed. So some of the things that we did determine that we needed to be able to standardize were really making some of the work processes that we had in place kind of prior to this innovation project and prior to COVID really apply to all of our referrals to Penn Medicine at Home, as well as to Penn Home Infusion. One of the key things from a HEMONC standpoint was really having one source of information. So within our EMR, we created a telephone encounter in which documentation of the referral to the home care agency would occur. At that time, during that, also the any lab orders that were needed, the medication order would all be very visible in that telephone encounter. We identified a disease-specific triage nurse who would kind of be our side of the liaison to Penn Home Infusion or Penn Care at Home, and that person became the primary contact for these weekly updates as far as administrations that did occur at home, and also kind of was able to document within that list for certain therapies. So for the EPOC patients, we needed one of the PSAs, so the schedulers at the front desk, to be able to schedule these patients so that their office visit, their lab visit, their infusion visit kind of lined up with when they were connected to start the home care. And so a lot of the things were really just making sure that everything was more visible to each person who might have contact with the patient. So whether it was the practice AA, the nurses, our triage nurses who might be managing symptoms, or one of the providers, all of this information was right in the chart. And now I'll hand it back over to Cass.
Thank you, Suzanne. So as you can imagine, and as Justin had stated earlier, this project has received a lot of interest and a lot of positive support, both inside of our health system as well as nationally. And some of the feedbacks that are direct from our providers are included on this slide here. And you can see things like how well timed it is, it's just-in-time effort. Obviously, that was really in response to the pandemic, But some of the things that are a little bit outside of that are that this could be the new normal. So transitioning things to becoming a standard of care, we seem to be getting that to the providers, which was great. And then one of the things that we heard from providers, both within the project, outside the project, and even from patients like Desiree, was how awesome this was. And we really think it was awesome, all the work that has gone into it. Justin had mentioned in the beginning the national coverage and interest that the project has received, and this slide is a little outdated at this point, but this represents a lot of the publications that have already occurred, highlighting the project and the outcomes that we've had. What is not on here is a very recent podcast that Catherine and Justin were invited to and involved in from ASCO about this project and how we had worked through it. So if we kind of return to our beginning, the project determined that home cancer treatment can, for appropriate anti-cancer therapies, for the patients and the populations, that can happen inpatient or at home, and we can do it safely and effectively. One of the opportunities we have is really that we need to continue that transparency that Suzanne was talking about, kind of between having two different EMR systems. So we need to improve our transparency, our coordination, and our communication between providers and the patients and the home infusion team. The project has definitely provided us with a good foundation for any future programs that come our way. We think we've shown that we can be flexible and adaptable and meet patient needs. So we want to thank you very much for allowing us to share this project with you. And I'm now going to turn it back to Jen for questions.
Great, thanks all. That was a great presentation. I know my notepad is filled with notes here, and we do have some great questions coming in. So first off, could you explain your nurse training program that you used to implement the successful launch?
Hi, this is Catherine. Catherine Major. I'm the director for nursing at Penn Home Infusion Therapy. So what we used the ONS certification for the nurses. We provided classes here through our nursing development department, and then we also provided hands-on training for the nurses. So that way they had both the didactic and the hands-on, and then they would take the certification exam. Thank you for your question.
Yeah, great. Thank you very much. Could you speak to some of the challenges and solutions related to patient coverage for these drugs at home?
Sure, I can take that. So we had a lot of challenges with some of the payer mixes that we see in our health system. We did a lot of working with our intake and our authorization team to get as many patients the benefits that they needed. As part of a large health system, we have financial assistance opportunities available as well that patients were able to apply for and be evaluated for. We've had some other opportunities to work with manufacturers directly for some of the therapies if they've had patient assistance or copay assistance programs as well.
Yeah, and an add-on question to that, have you struggled at all with insurers wanting to supply the medication through their own specialty or oncology pharmacy?
We have. There are a lot of payers that have recently actually changed some policies as early as, or as recent, I should say, as the beginning of October, that have requested, medications come directly from their specialty pharmacies. And then, they're asking us to provide them as part of the Penn Health system. We don't offer those services. So we work with patients to either kind of get some non-par sort of coverage for them that'll allow us to be able to still provide the nursing portion of administration, or we work with them to transfer them to an infusion provider that can help in that situation.
Great, thank you very much. So what has the response been from physicians to the program? Are they embracing it? What concerns have they expressed, if any, and how did you address them? Oh, Suzanne, you're on mute, I think.
I think some of the challenge, I think everyone was very on board with this during the pandemic. It was definitely a big push to get providers, so both physicians and advanced practice providers, to be accepting of this program and looking at different ways of administering therapies to our patients. I will say, I think the therapies that have to, the two therapies that we kind of started with, so Lupron and EPOC, I think this is the new standard way that we would administer these therapies. So there's been very positive reception to being able to do this at home. Some of other therapies where I think there still are some challenges, I think, just because patients need labs. Sometimes I will say as a provider, you want to be able to assess a patient, really look at them. And, that's really the ones that maybe haven't transitioned as easily. It's because there's still the need for an in-person visit kind of prior to the home infusion. But it's been very positive feedback.
That's great. That's great. Yeah, I certainly did a lot of planning to be able to get that positive feedback from the beginning. So how did you, I think this will probably be for Catherine, how did you handle the hazardous waste generated in the home setting?
So in partnership with Cass's team, Cass oversees the warehouse and the delivery team. And so what we did was we sent patients receptacles for their waste, and then Cass's team would pick that up for them. So when the nurse came out for the initial visit, that person would describe to them proper storage to keep it away from pets and children, and to make sure that it was stored safely and where it's not going to impact the efficacy of the medication. And then they were educated on how to put it into the correct receptacles for Cass's team to pick up.
Great, thank you.
Sure.
All right, this one's for Susan. Are you generating the order set out of CPR Plus or Epic? How does that collaboration work?
So on our side of things, we are using Epic. So we are sending an order, like we're sending the consult to Penn Home Infusion or Penn Care at Home, depending on the agent. And then we're writing an outpatient prescription and sending that to Penn Home Infusion for filling. And then Cass could talk about maybe what it looks like when it comes through. But for us, like we are sending a regular prescription and just selecting Penn Home Infusion as the pharmacy.
Yeah, so it's the typical outpatient prescription generation kind of process that's going through. So it comes over as a e-fax directly to Penn Home Infusion Therapy, and then we save that as just like an image in CPR Plus and use that as the prescription to fill.
Great, thank you. Can you maybe describe the financial benefit to the health system and to the patients, if there was one?
I'm sure that a lot of the work on the back end is going through financial and return on investment. I think the initial focus on this was really patient safety and just proving that we were able to do this in the home safely and effectively. I don't think anyone on the call right now has been involved in any of the financial discussions.
Okay, that's great. All right, so here's our question. Are you looking to include other PD-1, PD-L1 agents? Additionally, can you share what Keytruda is being compounded in the home or clean room?
I mean, I will say from a provider interest in other checkpoint inhibitors, I think that has in the past given other checkpoint inhibitors. So it's not that that as a home infusion company that they've only given Pembro. We had selected that as a pilot because there was a very specific group of patients that it was being piloted in. So it was the group of patients that was selected were considered super stable patients. So patients with lung cancer who had been on Pembro for at least 6 to 12 months, had not had immune-mediated adverse reactions, had not had an infusion reaction, and were kind of part of one very specific practice. So it was a pilot that was, it's a pilot that was done and continues. But I think some of the things that I mentioned before are some of the reasons why probably not every PD-1 inhibitor, every PD-L1 inhibitor is going to be administered at home, kind of from now until the end of time, just because patients do need labs, like we need to see their labs. We want to evaluate them, very often in person prior to administering those therapies.
Thanks.
And we have,
yeah, go ahead.
Sorry, we have done evaluations of them based on where we see site of care and site of care shifts coming from. So it is, when we look at kind of next steps with this and potential therapies that will be added, I do think that they're probably logically, to Suzanne's point, the population of patients is there, but it's just which patients do we feel are safe enough to go ahead and move into that space versus keeping in one of the clinical or more closely monitored areas.
Great. I don't know, Cash, could you speak to the compounding of Keytruda?
Yes, so our geographic area is one such that we compound everything on site for the most part, unless it's immediately requires immediate stability, but we can get our deliveries to patients pretty quickly. So we do compound in our clean room.
Great. All right, could someone speak to the team's handling of the timing of labs that are required prior to infusion?
So I think I'll say, so I think with Lupron, it's much easier. There's not quite as much of an issue with labs in a patient's like next Lupron injection. So I think a lot of times patients are having labs drawn essentially on the day, like sometimes on the day that the nurse is going out to the house to administer the therapy. With some of the pilots that were done with chemotherapy or checkpoint inhibitor therapy, those labs were sometimes a little bit more complicated, where patients, I'll say for like rituximab or bortezomib, the labs were often done on the same day. For the pembrolizumab trial, like the patients did have to have labs in advance of that home infusion visit. So there was various ways that was accomplished. For some high-risk patients, it was like a second visit by the nurse that was going out to the house. For other patients, sometimes they did have to go to sometimes they did go to a lab to get labs drawn in advance of their planned infusion.
Great, thank you. So I know you had put up the slide of where you're working with ASCO and such, but has Penn worked with other practice organizations to help expand the home infusion and their learnings? And how about payers? Have you been able to work with payers?
Yeah, I think that's probably some of those bigger questions that the three of us aren't necessarily involved in those conversations, but I can say I know that there have been a lot of conversations with insurers as far as coverage, both prior to the pandemic and then during the pandemic, and kind of as different therapies were being considered for piloting.
Thanks.
And Jen, I'm sorry, I didn't mean to cut you off there. We have been asked recently to start a conversation with NCCN, had reached out to us just to try to gain some of our knowledge and experience that they potentially could add to their toolkit and then be able to share universally across all programs.
Great. What data did you collect to show the value and efficacy of your program at home?
A lot of it initially was really based on patient and provider satisfaction. So there were a lot of patient ranking scores and provider ranking scores to really get the understanding of, did patients feel comfortable with having these therapies in the home? Because that was some of the initial kind of feedback we were getting is, oh, patients aren't going to be comfortable hearing chemo in my house. And providers kind of the same way. Is it safe? Is it effective? So our initial portion was that really seeing what the acceptability of the program was to shift these out of the inpatient setting or the clinical setting to the home. Some of the others, obviously, with some of the slides we showed, was just number of referrals. So number of patients that we were able to transition, and then kind of based on referrals to total transition to home. So obviously some patients that were referred were not, we weren't able to transition them to home for one reason or another, whether it was insurance participation or kind of the financial out of pockets, or some patients with COVID actually, while they didn't want to go downtown, they additionally didn't want people in their homes. So they were trying to figure out alternative ways to get their therapies. And then, to the point earlier, I'm sure there was a financial evaluation to it. I just don't believe that any of us that are here currently can speak to that.
Great, thank you very much. So with such a large geographic territory for you to cover, did you collaborate with home infusion or home health organizations to accommodate the coverage needs?
Hi, this is Catherine. I can speak to that. So we have a partnership under Penn Medicine Home Health where we already have nurses that are going to the home to administer things like, dressing changes for wounds or Clorox drains. So we tapped into that resource and first reached out to them and said, who's interested in learning more about chemotherapy and oncology? And started off with volunteers of nurses who were really excited about this new opportunity to learn how to expand their practice. So we did utilize our own internal nursing staffing that we had, and then we do partner with outside agencies for our outlying areas and for patients who live really far out.
Thank you very much. So obviously with COVID really expanded your program, but what prompted you to start this program in the beginning, even before we knew COVID was coming?
I think that actually goes all the way back probably to the second or third slide that Justin presented, and it really was just us looking at it saying, we know we can do better. Like just the health system, like looking at these patients coming in, looking at the volume of patients and the amount of time that they were spending in the clinic between the labs and waiting for an appointment chair and things like that. And it really was just the question of, we know we can do better. Now, what do we have to do to actually do better?
Great. So do you have any concerns about the USP 800 guidelines? I think someone's really asking specific to the closed system transfer devices for administration. What are your thoughts on that?
We always do, just with a lot of the changes and things, but we've used our loop runs with closed system transfer devices. We've had some injections with the ability to put them on. So they're integrated. Our nurses are well versed in how to utilize them. If there's any issue with them, they call into the office and speak directly with a staff member here. So I knock on wood, and I am knocking on wood on my desk. We have luckily been pretty good with them. Initially, I would say, just to share a story, initially with EPOC, when we transitioned to a particular closed system device and the tubing that we had to utilize, it did cause a increased pressure that was causing some pump alarms to occur. So my one pharmacy supervisor became a detective and figured it out, and we were able to bring that information back to the cancer service line team, explain to them what was going on, and then as a group, we partnered to how to overcome that. And ultimately, it was switching to large bore tubing and then moderating the fluid volumes to accommodate.
Thank you. Lots of challenges you guys overcame. Here's another nursing question. How do your OCN nurses meet the minimum number of oncology care hours each year in order to qualify for the certification? Maybe you could speak to the ability to focus their practice and extend oncology.
Sure. So as we partnered with the suites, we were able to transition some of those nurses to get the oncology hours, or to go out with other nurses that are already oncology certified and pair with them in the home to get the hours that are required.
Great, thank you. I think we talked a little bit about the great press that you received on what you're doing, but maybe you could talk a little bit about the naysayers and how your focus is kind of moving some of those naysayers into the value of home infusion for oncology.
I don't know if you're waiting for me, but I think it's not that I think everyone recognizes the value of home infusion. I think there's high utilization. I mean, Catherine and Cass could probably talk to this more, but I think across the board, there's pretty high utilization of home infusion by HEMONC, and particularly by HEMONC here. I think, kind of for some, I think sometimes people are, might take a little bit longer to adapt to giving an anti-cancer therapy at home. And I think that's really what you're, more asking about. But I think kind of being able to show the success of the pilots that have been done. Also, I think the integration of the two EMRs is huge. I mean, it really happened quite recently that, for the home infusion patients that integration occurred. So I think that is going to smooth, kind of the, some of this transition even more so than it had been. Just because it's hard, feeling like you have less control if someone's getting something at home and not kind of in front of you.
Yeah. Any other thoughts on that?
I think a lot of what we hear kind of in that naysay is you can't do this, it's not safe. And kind of to Suzanne's point, through the pilot, we have really proven, like through all of our steps, just with our general infrastructure and the way that we evaluate therapies, safety is really at the top of our forefront. I mean, it's really what we do. Patient safety and satisfaction from a Penn medicine standpoint, it's just inherent in all of us. And then the other side of things that we hear a lot is like the nurses. Well, you're sending an infusion nurse. They're not skilled to do chemotherapy. They don't know what they're doing. And we can say, well, no, all of our nurses are skilled and certified, and they're trained and they do provide this in the home, and they're experienced to provide it in the home. So not that we would kind of go head to head with these folks, but I do think our program and our resources and our staff actually have shown that the things that they have said, the reasons why they say this can't be done in the home, we've already proven, and we have the experience to say why it can be done in the home safely.
Great point, Cass. So we still have questions coming in, but we're just past time. So for anybody that we did not get a chance to answer your question, I'll either forward your question off to the Penn Medicine team, or I can kind of follow up with you individually. So many thanks to McKesson for the generous support of the COVID-19 series, and to our team here who has shared their expert knowledge with us. I think you guys had the most questions that we've ever had on the webinar. So I think that seems like home infusion is ripe for this, and people are really engaged in it. So we really appreciate you sharing. As a quick reminder, in order to get CE, please follow the link in the follow-up email to take a short quiz within 24 hours. On deck for webinars, we still have more education coming. Next Tuesday, we will have our Medicare program focused on the changing parenteral and enteral nutrition coverage. And then next Thursday on the 29th, we have a COVID-19 vaccine update. So plenty of education coming your way. We would like to thank all our providers and suppliers who are working on the front lines to keep patients safely in their home. We're looking forward to bringing you more education each week. Enjoy the day and stay safe.
Thank you.